My name is Dr. Kenneth Taylor. I'm the director of the Hypertrophic Cardiomyopathy Program here at Piedmont. Today we are here to discuss electrophysiologic issues in hypertrophic cardiomyopathy. And it is my honor to have Dr. Michael Hoosien here with me to help with this discussion. Michael is our director of the Atrial Fibrillation Program and also part of the Hypertrophic Cardiomyopathy team here at Piedmont. And I'm hoping we'll have a conversation about the most common issues related to the electrophysiologic world in hypertrophic cardiomyopathy. Michael, I want you to start by telling us a little bit about your background and your position here at Piedmont as it relates both to electrophysiology and hypertrophic cardiomyopathy.
Sure. I did my initial training at the University of Miami in Florida, went to Cleveland, did my cardiology and electrophysiology fellowships at the Cleveland Clinic, and then came straight here to Piedmont, so I've been here about 7 years. Always been very interested in atrial fibrillation, so we started the AFib program when I got here, and then also very interested in hypertrophic cardiomyopathy and other infiltrative diseases.
Fabulous. As we all know, patients with hypertrophic cardiomyopathy can have a number of electrophysiologic issues. Our goal today is to discuss these issues and to learn more about them. Let's start with probably the most important issue that faces patients with hypertrophic cardiomyopathy, and that being their risk for sudden cardiac death. We all know that patients with HCM are at increased risk for many arrhythmias, including more dangerous ones from the ventricles. Can you tell me your approach to assessing the risk of patients with HCM for sudden cardiac death?
Yeah, I want to make two comments up front. The first one is, I think that whole decision-making process we've now realized is as much art as it is science. So we do have some guiding principles, but certainly a very in-depth discussion with the patient, joint decision-making is critically important, and really looking at the individual in terms of age, other comorbid problems, risk factors, all of that needs to be taken into account. And then I think there is a lot to be said for experience as well. And I think those of us who have had more time to treat these patients learn things along the way.
As a follow-up to that, I'm interested in your opinion regarding HCM risk calculator versus clinical risk assessment, and the art is kind of playing into that. Historically, the U.S. model, which is based on major risk factors, which you might touch on, tends to have a higher sensitivity, whereas the European model, which is based more on individual risk calculator, has a higher specificity. I'm curious about your thought on this dichotomy, the specific risk factors, and how you might use one or both of these together.
Sure. So starting off with the European risk calculator. So as you mentioned, this takes several variables into account, and then you get an estimate of 5-year risk of a potentially fatal ventricular arrhythmia. And for them, the typical cutoff right now is 6%. So once you eclipse that 6%, it's also important to mention that there is no class 1 indication here or in Europe for ICD implantation, but 6% is the cutoff for more strongly recommending it. The other important point with the risk calculator, there are some variables that we now know play a big role in terms of risk that traditionally were not included in the risk calculator, which makes it very specific but not as sensitive. In other words, there are potentially patients out there who would benefit from an ICD but are not offered an ICD implant.
Right.
And the opposite is true for how we assess risk traditionally here in the United States, looking at individual risk factors. In that case, we do take into account some of those variables that were not included originally in the European risk calculator. So this would be apical aneurysms, LV systolic dysfunction, how much fibrosis or scar we discover on an MRI. And the opposite is true for the United States approach. So very sensitive, but less specific. And in that scenario, there are people that may be getting ICDs that potentially don't really warrant ICD implant. So those are the two dichotomous ways to approach this. Me personally and both societies have adopted this approach, and that is to integrate both together. So you can utilize the risk calculator, but then also take into account some of those other variables that we now know are definitely associated with heightened risk.
Sure, and I think that's where the art of managing these patients comes in. Our current guidelines have incorporated some of these other factors into the guidelines, including mid-wall enhancement on MRI and apical aneurysms, as you mentioned. I'm curious the guidelines recommend monitoring patients for ventricular arrhythmias on a very regular basis. And I'm curious, your use of the monitoring, I have two questions. One, what kinds of numbers of ventricular arrhythmias do you get concerned about? What types of lengths of non-sustained ventricular tachycardia? And then I'd like to have a conversation about your use of ILRs.
Sure. I think the first question is, when we're talking about ambulatory monitors, what time frame or length of monitoring is really appropriate and what's going to yield the data that we're actually looking for. So traditionally, 48-hour Holter monitoring has been what most clinicians look to. It turns out that there is some data suggesting if you, for instance, put a 14-day monitor on a patient, there's a good chance if you are going to pick up any ventricular arrhythmias, it's going to be beyond that initial 48-hour mark. So there may be significant utility in more prolonged monitoring, 12 to 14 days, just because, again, the sensitivity is going to be a lot higher. The number of episodes, I'm not sure how important that is necessarily as a variable. I would say the type of ventricular tachycardia that we're talking about, meaning is it symptomatic? How rapid is it? So I think once you're, again, eclipsing that 200 beats per minute in terms of the cycle length, I tend to worry about that a little bit more. Duration, I think a hard cutoff for me would be 10 seconds, but multiple episodes that are more than 5 seconds in duration, that also is a little bit concerning. And then the frequency of monitoring is another important question. So I think if we do more extended ambulatory monitoring, once annually is probably reasonable, unless there is some change. So if there is, accelerated fibrosis on MRI, maybe going to something more in the biannual range. And then as far as the loop recorders go, again, a very in-depth discussion with the patient in terms of what they prefer to do. But once I see more than one risk factor, plus any white complex tachycardia on an ambulatory monitor, I think a loop recorder is very reasonable, especially in the younger cohort of individuals.
Sure.
Yeah,
we in the non-EP world have shifted towards using 14-day monitors pretty routinely. And I tend to send patients to you for ILR consideration when they kind of fall into that intermediate zone, when they're not low risk and they're not high risk, and I'm not sure. And there's a lot of debate about whether ILRs should be used in that situation, but I think that's not an unreasonable place.
Yeah, especially because of the additional data that we get above and beyond ventricular arrhythmias. Obviously, these patients are very prone to atrial arrhythmias also, and I think that's useful data that could also be a harbinger for progression of the disease. And again, with an implanted monitor, we're much more likely to pick up on that subclinical atrial fibrillation that over time can progress.
That's a perfect segue into my next section. I was hoping next to turn our attention to atrial fibrillation. Tell me about your general approach to management of AFib, and if there are any differences in your general approach to AFib in the hypertrophic cohort particularly.
Yeah, these days, I think most of us in the field have definitely moved towards prioritizing rhythm control, number one, and then really working on early rhythm control, number two. The data is very convincing that people tend to do a lot better if we are more proactive versus reactive when it comes to atrial arrhythmias. Part of that has to do with preventing progression. Quality of life tends to be better if we intervene earlier. There is also very compelling data favoring catheter ablation early, even as a first line, without having to fail an antiarrhythmia drug. And all of that, I think, is even more so true for the hypertrophic population. I think they are more prone to developing heart failure symptoms. There's probably an impact on ventricular remodeling also, even though it's an atrial problem. And I think they are more likely to progress much faster. So in general, I'm pretty aggressive when it comes to early rhythm control. For the hypertrophs, even more so.
Sure. Sure. Yeah, in my experience, patients with hypertrophic cardiomyopathy don't tolerate AFib very well. It's relatively uncommon to have asymptomatic hypertrophic cardiomyopathy patients with AFib. So
I would agree with that.
I support a very aggressive approach. Tell me about your use of antiarrhythmic drugs, particularly choice of antiarrhythmic drugs, and when you might go to an antiarrhythmic drug versus catheter-based therapies.
Yeah, sure. So when it comes to the drugs, obviously the class 1C agents are not going to be options here since we're talking about a hypertrophic substrate. So we're left with class 3 drugs and disopyramide.
Right.
So I, generally speaking, am a big fan of sotalol. Because we get some degree of control of ventricular arrhythmias as well, especially somebody younger that already has a defibrillator. I think sotalol makes a lot of sense as an antiarrhythmic agent. I think if we're not necessarily worried about controlling ventricular arrhythmias, disopyramide is not a bad option, especially given the negative inotropic effects. You get that bonus effect from the medication. Dofetilide and amiodarone both seem to be safe in the hypertrophic population based on several studies. But again, if I'm deciding between sotalol and dofetilide, I probably more so favor sotalol because of its beta blocker properties and its impact on ventricular arrhythmias. And then amiodarone I really just reserve for people that we don't want to put on any of these other agents.
Sure.
And then the ablation question. So the HCM population is underrepresented in essentially every big catheter ablation trial that's been done. So we don't know as much in terms of how well they do with ablation compared to the general population. But there is some data out there to suggest that they do just as well with upfront ablation, perhaps even more so than individuals that are not hypertrophics. So in the younger group especially, that is a very extensive discussion that I have with them. And a lot of them do opt for ablation upfront, in part because they want to avoid using drugs. They want to avoid using drugs that could be pro-arrhythmic. So I think we are definitely moving more so in that direction than in the past.
With the new ablation techniques, do you think that is any different in the hypertrophic world, or is it just the same as the rest of the afibrillation world?
No, I think, you're referring to pulse field ablation,
right,
which is not completely non-thermal, but it is essentially non-thermal compared to our more traditional ablation tools. And one of the big advantages for this is we can debulk a lot of substrate in the left atrium, especially in the posterior wall, without as much concern for things like esophageal injury. And I know from experience that people with hypertrophic cardiomyopathy tend to have an atrial myopathy that tends to be disproportionate to the amount of atrial fibrillation that they've had. Okay. So it's not unusual when we're mapping during an ablation to see pretty extensive atrial scar, despite the AFib still being paroxysmal. Right. And so in those types of cases, for an initial ablation, I think most of us probably would not have ablated very aggressively on the posterior wall because of that risk of esophageal injury.
Right.
But that whole thinking is changing now as we get more experience with pulse field catheters. So we'll have to see how things shake out over the next 3 to 5 years, but it's conceivable that the hypertrophic patients will do a lot better than they have done historically if we're able to address the substrate in the left atrium a little bit more aggressively.
That's great. Let's talk a little bit about defibrillators. The choice of defibrillators, once you get to the point where there's a decision made, obviously there are a lot of different options these days. And I'm curious if, in general, your approach to defibrillator choice and specifically in the hypertrophic world, if there's any nuance to that.
I think we tend to see a lot of younger individuals coming in for that discussion. And I think in the younger group, it certainly would make a lot of sense to strongly favor a subcutaneous implant versus a transvenous. Until recently, I felt somebody may benefit from anti-tachycardia pacing.
Right.
Of course, we would have then favored a transvenous system to have that feature, but that's going to be changing very soon as far as the Boston Scientific subcutaneous defibrillator is concerned, because they relatively soon, we think, we'll have a leadless pacemaker, and the two can communicate with one another. And so even though you've got a subcutaneous defibrillator system, you can still benefit from anti-tachycardia pacing. And Medtronic relatively recently got approval for their subcutaneous system. And what's different between the two is the electrode is substernal in Medtronic's system. So again, that does provide for anti-tachycardia pacing. But in general, I think much more so a subcutaneous than a transvenous system.
I guess the other issue is whether pacing is needed, and oftentimes in a hypertrophic population that's not usually as much of an issue, though sometimes with obstructive disease, when we have people on high-dose beta blockers and calcium channel blockers, that can become more important.
And it's an interesting point, actually. In the vast majority of individuals, pacing from the right ventricular apex is very detrimental from a hemodynamic point of view. But in hypertrophics who do have outflow tract obstruction, it actually turns out that the desynchrony oftentimes will improve the obstruction, improve the gradients, and so they counterintuitively actually benefit from apical pacing, which is a funny thing to think about now because as electrophysiologists, we're all focusing on conduction system pacing.
I'm old enough to remember when those trials were done where we thought we were actually going to help gradients with it, and unfortunately the clinical trials were not beneficial. Yeah. Very good. Let's talk a little bit more about, well actually, one more last question on the AFib ablation and then we'll go to ventricular arrhythmias. I just recently had a patient that raised this question. In patients who have, we know that patients who have hypertrophic cardiomyopathy require anticoagulation regardless of their CHA2DS2-VASc score. And I'm curious, in patients who have undergone ablation, oftentimes we actually can stop their anticoagulation after a period of time once they've been ablated. And I'm curious your approach in hypertrophic patients, what you think about that and whether there's any role for being able to discontinue anticoagulant therapy.
Yeah. So there's a lot of interest in this topic generally. Given the improvement in ablation technology outcomes and the existence of very good wearable technology, coupled with anticoagulants that are very rapidly acting, there is interest in the concept of taking an anticoagulant on an as-needed basis. So for more extended episodes of atrial fibrillation, atrial flutter, then a patient would take a dose, reassess over the ensuing days, but not necessarily take a dose every day. This is not something that I really encourage any of the hypertrophic patients to do, because I think there is an element that we don't completely understand as far as the thrombogenicity in the atrium. So right now, pending further data, it's not something that I encourage them to do.
I totally agree with that. And part of that is that, unfortunately, as you mentioned about the other studies, hypertrophic patients have been less well represented in a lot of the clinical trials, so we really kind of don't know. Right. Very good. So let's talk a little bit about VT ablation. And do you do much VT ablation in patients with hypertrophic cardiomyopathy, and are there any differences compared to the general population?
Yeah, I would say in general, we probably do less in the hypertrophic population. The individuals that probably still get offered VT ablation most frequently would be those with endocardial scar. So this would be the ischemic substrate.
Right.
The non-ischemics tend to have a lot of paravalvular scar. A lot of it is mid-myocardial, epicardial. So they still derive benefit from VT ablation, but probably not quite as clear-cut as for the ischemic substrate. I think part of the challenge with a hypertrophic patient is really defining the distribution of scar and its location within the myocardium. So I think if they come in with monomorphic VT that is relatively stable, and we can demonstrate that there is at least some endocardial scar that we could target for ablation. So some of the data, small trials, but some of those studies do suggest that they derive significant benefit. But again, not very well represented in the bigger VT ablation trials. So we don't know with certainty, but there is a signal for benefit.
Interesting.
And the other thing.
Please.
It turns out that a lot of the ventricular arrhythmias that they have are re-entrants. And again, if that's true, catheter ablation could decrease the likelihood they have recurrent VT and decrease the likelihood they suffer recurrent shocks.
Okay.
Yeah.
Do you see much of a difference in the different morphologic types of hypertrophic cardiomyopathy, obstructive, non-obstructive, mid, apical with scar, both as it relates to ventricular arrhythmias and atrial arrhythmias?
Certainly the apical aneurysm or the apical subtype, I think, for whatever reason, that substrate tends to be very arrhythmogenic. So again, if there's any suggestion that there is aneurysmal change, I would expect those subtypes to probably suffer from a lot more ventricular arrhythmia burden versus just a septal substrate.
Okay.
And then the septal substrate, because a lot of that VT is going to be utilizing the conduction system tissue, it also tends to be a little bit more tolerated hemodynamically. And, having to take them to the EP lab for an ablation, probably less likely than, a big aneurysmal fibrosed subtype.
Gotcha.
Yeah.
Gotcha. I'm curious, in patients who have undergone septal reduction therapy, and I'm mostly thinking about patients who have had myectomy, there are old data that suggests that their risk for long-term bad outcomes, including sudden cardiac death, come back closer to population-based. What is your approach in terms of risk monitoring in patients post-myectomy, alcohol septal ablation, and those may be very different.
Yeah.
And then maybe we might touch a little bit on cardiac myosin inhibitors.
Yeah, so right now, as far as estimating risk, whether we're talking about the European approach or the approach we typically use here in the US, whether you've had septal reduction really does not come into play. So I think I would still look at those other higher risk features. I think for a younger patient, especially if they've previously had very concerning syncope, for instance, and then undergo myectomy, I'd be hard pressed to assume that they go all the way back to the risk of someone in the general population. So as far as the defibrillator question is concerned, or the monitoring question, I'd probably still look at the risk factors that we utilize in the current scoring system, whether or not they've undergone septal myectomy.
Interesting. Yeah, I've always worried a little bit about those patients who undergo atrial septal ablation, because you're creating a scar in a patient population that is known to have arrhythmias from scar.
Right. And
I gather the outcome data aren't as concerning as one would expect, but I've always been a little more worried and a little more concerned about arrhythmias. Also, when you do MRIs, trying to figure out how much of their scar is from the ablation and how much is from the underlying disease process can be challenging.
Yeah, it's a good question whether, and like you said, whether it's surgical myectomy or an alcohol ablation, whether this could in certain situations actually be pro-arrhythmic or not. I'm not aware of any compelling data to suggest it, but I think from a mechanistic point of view, it is an important question.
Sure.
Yeah.
And I think we're all going to have to learn with the institution of cardiac myosin inhibitors how that's going to affect arrhythmic risk, both ventricular and atrial.
Yeah, and even if you extrapolate beyond the hypertrophic cardiomyopathy cohort in general, this is a big question as far as defibrillators go.
Right.
In the era of really excellent guideline-directed medical therapy, do the original primary prevention trials still apply?
Right.
Yeah,
Right.
and we'll have to try to answer the same question with the myosin inhibitors.
I think it's going to be very interesting because we're starting to see markers for even reverse remodeling, septal thickness reducing, and most notably, and I'm seeing a lot of atria coming back into normal sizes,
Yeah.
whether we're going to see a significant change in arrhythmic risk, both ventricular and atrial.
Yeah, and for us, I think it's going to be very interesting to see what these atria look like for the people that are coming in for an ablation.
Right.
I think that's going to be a very, very interesting question that I imagine we'll have some answers to over the next 5 years.
Very good. Yeah. Very good. I think that's most of what I wanted to talk about. If there are any major issues that you wanted to raise, please let me know. Otherwise, we can kind of begin wrapping it up. Yeah,
the only other topic that I think is still germane to this is, how do we manage the appendage in these types of individuals?
Sure.
And again, just like the ablation trial point that I made earlier, it turns out in the appendage management trials, hypertrophic cardiomyopathy patients are very underrepresented. So it's another one of those questions that we don't have a good answer to. There are some smaller studies that do suggest a higher ischemic stroke risk in HCM patients post-appendage occlusion or closure. Again, which begs the question, is there something else thrombogenic going on beyond the appendage? So I think, especially in that population, my advice to those patients would be, we should really only consider this for you if we have a very strong indication. So, things like patient preference, somewhat frequent falls, I would be very hesitant to feel that they are safe coming off an anticoagulant altogether, even with an appendage closure.
So mostly for patients who really have severe bleeding diatheses and really are contraindicated to stay on anticoagulant therapy. I think it's totally fair. Good. Very good. Well, Michael, thank you so much. It's been a great conversation. I've learned a lot, and I think hopefully our audience has as well. And I look forward to more in the future.
Okay. Pleasure to be here.
All right.